Hello everyone, this is Alka Rani and welcome to the mini lecture of Nursing 6630N. Today we are going to talk about one of the most important concepts in psychopharmacology, the agonist-to-antagonist spectrum. If you ever wondered why some drugs activate receptors, why others block them, and why drugs like eprizolol and called partial agonist, the episode is for you. By the end of these 5 minutes, you will be clear framework of understanding how different psychiatric medication act at the receptor level. Let's go and get started. So let's start it. What is the agonist-to-antagonist spectrum is? Imagine the light dimmer switch at full brightness. The light completely on. At the medium, it is partially on. At off, it's no light. And then imagine a switch that not only turns the light off, but actively prevent anyone else from turning it on. That's agonist-to-antagonist spectrum. On one end, we will have full agonist. These bind to receptor and produce the maximum possible response. Think of dopamine activating D2 receptor, that full agonist effect. Many drugs are used are full agonist, like benzodiazepine at GABA A receptor. Moving down the spectrum, we have partial agonist. This also bind to receptor, but they produce only a partial response, even if every receptor is occupied. Abilify is a classic example at D2 receptor. It produces about 25 to 30% of the full dopamine response. That's why its stabilized dopamine activity is raised low activity and lower high activity. So antagonist and inverse agnostics. Next are antagonists. These bind to receptor but do not activate them. Instead, they block other molecules from binding, like haltoperidol is a D2 antagonist, blocks dopamine from activating the receptors, which help reduce psychosis. However, antagonists don't reduce baseline receptor activities. They just prevent stimulation. And the far end of the spectrum are inverse agonists. These do not oppose it to an agonist. They reduced baseline receptor activity below is normal level. While real psychiatry, some antihistamine and beta blockers work this way, most psychiatric antagonist is actually natural antagonist, meaning they only block without reducing baseline activity. Why does this matter for PsychMP? Understanding the spectrum directly affect prescribing. Let me give you 2 examples. First, consider a patient with the schizophrenia who has a partial response to full D2 antagonist. Switching to a partial and agnostic, that eprizolol may improve negative symptoms and reduce side effects like hyperpolyractemia, because it doesn't fully block dopamine, is only partially activate. Second, think about opioid use disorder. Buspar is a partial agnostic and mu opioid receptors, enough to reduce craving and withdrawing, but not enough to cause full euphoria or receptor distress. Naloxone is an antagonist. It's completely blocked the receptor, revising the overdose. So to summarize, full agnostic turn receptor full on, partial agnostic turns them partially on, antagonistic block activation. And inverse agnostic turn baseline activity down. As a future psychiatric nurse practitioner, knowing where your medication falls on the spectrum help you predict clinical effect, side effect, and even withdrawal risk. Thank you for listening. I look forward for our discussion. Thank you.